to talk to you all today. Really appreciate it. So these are my disclosures, but there are no disclosures or conflicts of interest in relation to any of the work that's going to be presented in this talk. So very sadly and unfortunately, we're all very familiar with this now, as of the last year, that we're in the midst still of a pandemic. And as we all know, this is due to severe acute respiratory syndrome, coronavirus 2. And the only reason I mention this is obviously because we all know this already, is because it is primarily a respiratory illness. It's primarily a respiratory infection. And obviously the focus of the talk today is about potential cardiac sequelae, but primarily a respiratory infection. Nevertheless, we do know that patients who have established cardiovascular disease and cardiovascular risk factors, they represent a more vulnerable patient group when suffering from COVID-19. And on the flip side, we also know that patients who experience cardiac injury as part of their COVID-19 illness, they have an increased morbidity and mortality. And by definition, myocardial injury is being demonstrated through elevated troponin. And fairly early on in the pandemic, this was a fairly common finding. So you can see these three early studies. There's just a selected three from China, very early experience in terms of observational cohorts and registries, showing roughly between 15 and 30% prevalence of myocardial injury in hospitalized patients with COVID-19. And it became apparent very quickly, this conferred a poorer prognosis, so worse in-hospital mortality. Now, I'm going to show you our initial early experience in the pandemic up until the 30th of April last year. So we looked at all patients in the trust who had been discharged, either alive or dead, who were PCR positive for SARS-CoV-2 up until the end of April. And there were 828 patients discharged either from the Royal Free, which is where I sit, or in Barnet Hospital, which is our sister hospital. And you can see that actually the proportion of troponin positivity was far higher in our experience than that in China. So just over 70% of patients in hospital had evidence of an elevated troponin. And then if you look further, you can see that actually there's a significant difference in mortality in hospital. So these are unadjusted data. These are totally raw data. But you can see here 41% versus 8% in hospital death, depending upon if you're troponin positive or troponin negative. So first and foremost, why were our data initially so different from the early Chinese experience? I think the first thing to say is we have no selection bias here. These are unadjusted data. So if you look at some of the Chinese data, there was one study by Zhu and colleagues that I think they excluded 77% of patients for no obvious reason, and then reported a roughly 17% prevalence of troponin positivity. These are completely unselected patients in our cohort. And our cohort is also far older. So median age of 71 years. We have an aging population in the UK. If you split by troponin positivity, the positive troponin group had a median age of 77 years old, whereas troponin negative were 56 years old. If you look at these three Chinese studies from top to bottom, the average ages are 49, 64, and 59. So a significantly younger cohort in the Chinese experience. And also with age, we get more comorbidity. Particularly in our patient population here at the Royal Free, there's far more renal patients because we are a renal hub. When any patients, dialysis patients, become unwell in the community, they come here. So we have far more renal patients, far more comorbid burden, and a far different demographic to that in China. So a lot of differences in terms of the populations, and that's probably accounting for our early experience. Now, we know that you get elevated troponin in lower respiratory tract infection, pneumonia, and we know that it's something that you shouldn't ignore. It can be a marker, obviously, of undiagnosed underlying cardiovascular disease, maybe arrhythmia, maybe coronary artery disease, etc. I've demonstrated in our experience it was very common in COVID-19 infection and conferred significant inpatient mortality. But what about the people going home? So what about the people who have come into hospital with COVID-19? These patients who are now troponin positive as part of their admission, what do we do with them? So in order to sort of figure out what the best way of investigating these patients, we thought it important if we know the actual underlying mechanisms or potential mechanisms of disease. And you can see from this, sort of simple cartoon from the tutorial last year in the EHJ, there are sort of four main mechanisms that were proposed. So ischemia, due to an imbalance in terms of supply-demand mismatch, probably fairly common. Myocardial infarction, so this could be macroangiopathic or microangiopathic. Obviously, COVID patients are very prothrombotic. The footnotes about being common or uncommon are part of the diagram and not necessarily our opinion, as we'll show later on, because actually it was probably more common than was initially thought. Myocarditis, and I think the definition of myocarditis is potentially important here. So is this demonstrating a lymphocytic infiltrator biopsy? Is this demonstrating virus actually in the myocardium? Is this an epiphenomenon of an inflammatory or systemic inflammatory syndrome? I think these are all different definitions in terms of what myocarditis is. So in terms of how common it is, it depends upon how you define it. And then finally, stress cardiomyopathy, which in terms of my sort of anecdotal experience, I didn't see a huge amount of Takotsubo cardiomyopathy in hospitalized COVID patients, but nevertheless, the potential mechanism. So the question arises, what modality could be useful as a one-stop shop for all of these? It comes as no surprise, given the title of the talk, that we chose CMR, because obviously that's what we do. But for those of you who are maybe less familiar or don't do CMR as much, just roughly speaking, this is what we can show. So in terms of inducible ischemia, these are two separate patients on the top row and the bottom row. So these are quantitative stress perfusion maps. So it's very much painting by numbers. You can see the scale on the left. This is after adenosine stress for 4 minutes, an infusion of adenosine, and then first pass perfusion with gadolinium. And the perfusion of the myocardium, or the myocardial blood flow, is quantitated and color coded. So you can see the top row from left to right is base to apex, 3 short axis slices in a patient who's got no evidence of inducible ischemia, normal hyperemic golden myocardium. The bottom row is one of our patients who had COVID-19, who was troponin positive, underwent a stress perfusion study, globally reduced myocardial blood flow. They had multivessel coronary artery disease that they never knew about. And in particular, there's a significant defect, particularly in the mid to distal anterior wall, mid-anteroseptum and the apex. So you can see here a patient with multivessel coronary artery disease by cardiac MR. What about myocarditis? So here are 2 images. One is a late gadolinium enhancement image and one is a native T1 map. If I start with a late gadolinium image, so gadolinium is the contrast agent we give, and it's gadolinium based. So the gadolinium is what appears bright white. It's bound to a chelate. That chelate makes it safe, and it makes it an extracellular contrast agent. So it resides in the extracellular space, be it scar, infarct, diffuse interstitial expansion, let's say an amyloid. And you can see here it's in a subepicardial distribution. So that's non-ischemic. And that's indicative in the lateral, wall, that's indicative of a myocarditis-like pattern. So that's a post-contrast image, but we can also do pre-contrast tissue characterization by referring to things called T1 and T2. And in short, in brief, T1 and T2 refer to timing parameters that are different for different types of tissue. So T1, for example, can be raised in edema, can be raised in some amyloid, infarct, focal fibrosis, scar. T2 is more specific for myocardial edema. And again, it's a painting by numbers approach. So the scale is adjusted, it's a color-coded scale, and each voxel in terms of the timing parameters is color-coded. So normal myocardium on this T1 map is purple, but you can see here in that similar subepicardial distribution, it's in the same patient, they have elevated T1 here. So again, it's a non-contrast tissue characterization methodology. Contrast that to myocardial infarction, where you see a subendocardial distribution of late gadolinium enhancement. In this patient in the infraseptum, inferior wall, but very subtly in the mid to distal anterior wall and septum. So this is a subendocardial pattern, an ischemic pattern, that this is MI. So you can actually demonstrate all these things in one test, and obviously this is what we do. And so we thought we'd apply this test to actually understand the mechanisms of troponin positivity in these patients. And at this point, I want to give a nod to Peter Kellman at the NIH, who collaborates with us. And these sequences at the bottom are sequences, well, they're his sequences, and it's a sort of clinical and academic collaboration for which we're very grateful, because they very much augment our both clinical and academic practice. So here at the Royal Free and in Barnet, measuring troponin was actually part of the care bundle of any suspected COVID patient as soon as they came into hospital fairly early on in the pandemic. So it was, measurement of troponin was standard of care, but at the time, early on, it was a pretty controversial thing. So The European Society of Cardiology fairly early on said that really we shouldn't be measuring troponin unless patients are having a type 1 MI type of presentation or new onset severe RV dysfunction, but they did make an exception in terms of prognostication. We didn't look at sort of the degree of elevation. Obviously we did clinically, but in terms of who we actually ended up inviting for a scan, we just said, did they have a high troponin or not? Some recommendations were suggesting people shouldn't be invited unless they have a troponin 3 times the upper limit of normal for further investigation. We just decided to investigate everyone with an abnormal troponin. But we were also mindful of recommendations for cardiac imaging at the time. There was a lot of sensitivity about what tests patients should be brought to hospital for in the middle of a pandemic. Resources were stretched. Staff were concerned about infection and also in terms of contamination of equipment and things. And so the Society for CMR did recommend deferring investigation until patients are no longer infectious. So with all that in mind, we set up a group of stakeholders in the hospital to make sure that actually across the board, people thought that this was a reasonable thing to do. And everyone did. You know, in normal circumstances, these patients would have some sort of investigation done. And we shouldn't really be making an exception if we can actually do this safely. So referring back to that earlier spider diagram of troponin positive patients who discharged alive, 347, you can see in terms of initially who we excluded, in terms of inviting back for a CMR, quite a lot of people were excluded. We thought at the time, you know, in the first wave of COVID, inviting 140 octogenarians wasn't necessarily in their best interests for a CMR. We excluded severe renal impairment. And also there were a lot of medically inappropriate patients. There were a lot of really frail individuals who actually bringing them back to hospital was quite a big deal and wasn't necessarily in their best interests, be it from a nursing home, residential home, or who had a lot of severe comorbidity that really impaired their functional status. So initially we scanned 51 of those patients. It included 7 patients who were swab negative, but who had the whole triad of classic symptoms of COVID-19, classic radiology, and blood biomarkers as well. We then submitted this for publication, and we were asked to restrict our findings to patients who had no prior knowledge of cardiovascular disease, also no presentations with things like type 1 MI, and no in-hospital diagnoses of PE, because it was felt that performing CMR on those individuals wasn't necessarily of value. And as you can see, what we were left with, 29 patients, and they had a handful of ischemic, non-ischemic, or mixed pathology. But if you take that back a step, prior to that sort of decision, that publication decision, if you look at those 51 patients, 6 presented with a type 1 MI via our primary angioplasty service with ST elevation infarct, and 45 had a troponin of unclear significance. But after convalescent CMR, actually there was an awful lot of underlying pathology. So in the type 1 MI group, you had 2 out of the 6 patients having not only ischemic looking late gadolinium enhancement, but also non-ischemic, indicative of concomitant myocarditis. There was a high degree of findings of myocarditis-like scar and lots of overlap in terms of myocarditis and ischemia, MI. And then if you look at the patients who had a CTPA, so I think only about 20 patients, I think, in this cohort had a CTPA as part of their admission. But of the overall 51, 24% had evidence of PE diagnosed during their admission. And then if you look at those patients, 2/3 of the patients who had PE actually had late gadolinium enhancement. 5 had myocarditis-like scar and 2 had myocardial infarction. So it's a matter of debate as to whether or not it was a value in terms of when we went to publication, but we felt actually it was a value because there was more going on than just PE in these patients. And then if you look at that green box at the end, 14 who had a normal cardiac MRI, 4 of those patients had PE. So really there were 10 patients left who had no obvious cause for their troponin leak. So at this point, we were thinking that, you know, this is actually a pretty useful test to be doing in these patients. There's a lot of disease here. Obviously, we can't necessarily attribute causality for all of this, but nevertheless, there's a far higher degree of disease burden than you'd expect just inviting in 50 patients or 50 individuals. So we were thinking this is pretty good. Later on in the year, there was a further study of convalescent CMR in recovered COVID-19 patients from Germany. Now, this study had fairly different findings from what I've just presented you in our cohort. So these were 100 patients who had COVID-19 infection and who recovered. A third of them were hospitalized, so 2/3 didn't go into hospital for their COVID-19 infection. Median time between diagnosis and CMR was 70 days, 71 days. Only 5% had evidence of an abnormal troponin at the time of their cardiac MR, but 78% had abnormal cardiac MR findings, and 60% had evidence of myocardial inflammation. And bearing in mind that 2/3 were not hospitalized patients. So this is very different from what we found. It attracted a lot of attention, a lot of critique on social media, which I'm not on and don't take part in. But nevertheless, I was aware there was an awful lot of critique online about this, whether data were presented as parametric or non-parametric, about data points on figures not necessarily correlating with some of the text. And so a month later, the data were republished, and a lot of study data had been changed, so much so that this affected the abstract, the methods, the results, all the tables, and 2 of the figures. But overall, the authors felt it didn't change the actual overall message, that there was a high degree of cardiac pathology going on in this cohort of 100 recovered patients, despite them being at the less severe end or the mild end of the spectrum of COVID-19 infection. Nevertheless, despite people's opinions, this attracted an enormous amount of media interest. So an altmetric score of nearly 14,000. I believe it postponed some of the college sports in the US, some of the big programs of college sport. It was in some of our newspapers, albeit one of our newspapers there is actually not one that medics are particularly happy with. But nevertheless, it caused an awful lot of media attention over here, and I think internationally. And a lot of worry, because what does this mean for people who are asymptomatic and patients just with mild infection? Is there ongoing significant cardiovascular disease across the board in people if you have a COVID infection, regardless of its severity? So in terms of where we are now in this talk, I presented you some of our early data that we published as a research letter in Circulation. And I've shown you some of the controversy surrounding a subsequent paper of convalescent CMR from Germany in recovered COVID-19. What I'm going to focus on in the remainder of this presentation are 2 CMR studies. So the first is a multi-center registry study of severe hospitalized COVID-19 patients from London that we've recently published in EHJ. And the second one of the role or not of CMR in mild COVID-19 disease in a paper that's just been accepted from James Moon's group. And then finally, I'm going to just make a comment on future studies to hopefully untangle some of these questions. So this map of London is zoomed in on central North London and part of West London. And the 6 pins are different hospitals in the region. And if I take you through these hospitals, so I work on the top right in the Royal Free, and we're also paired up with Barnet as part of the Royal Free London NHS Trust. The Royal Free is in the dark there because unfortunately in the daylight it's a sort of 60s grey concrete tower block, so it's not as attractive in daylight. These 3 hospitals, middle left is Hammersmith, bottom left is Charing Cross, and bottom right is St Mary's Hospital with the black cab outside the front. These make up Imperial College Healthcare Trust, and then finally with the London bus in the front, UCLH in central London. Aside from all being in London, the other thing these hospitals all have in common is that myself and Mariana Fontana, we set up the CMR unit here at the Royal Free in January 2016. But we also were fellows together during our training alongside other fellows. So Graham Cole, who's now a consultant at Imperial College Healthcare Trust doing CMR. And also we were fellows alongside Tom Tribal when he was a fellow, and he's now a consultant at UCLH and Barts, and also doing CMR. So all 4 of us did CMR, we were all in London, we all worked together, and we decided to combine our scanners as a multi-center registry, because actually these 6 hospitals serve a population of 3.5 million patients. So we thought we were fairly well placed to look at the question of troponin positivity in hospitalized COVID-19. So we're now looking up until the 20th of June. We reviewed all discharges up until the 20th of June last year, so it's still the first wave of the pandemic. And just under 1,900 patients were discharged alive across those 6 hospitals after their COVID-19 admission. Now, if we look at troponin positive and troponin negative, it wasn't a standard of care across all trusts to measure troponin as part of admission from the outset. So just over 1,000 patients were excluded, either because troponin was not measured or because their patients were troponin negative. Then this was whittled down to 148 patients who came for convalescent CMR. It's unsurprising that there were a fair number of patients who didn't want to reattend hospital. We had contraindications. Inappropriate is a bit of an odd word there, because really that includes things like severe renal dysfunction. Again, we excluded very elderly patients, very frail patients. But nevertheless, we invited 148 patients for convalescent CMR. And the majority underwent a full study, including contrast and native tissue mapping. The minority didn't have tissue mapping, and only 4 had a non-contrast study for various reasons on the day. 76 individuals had adenosine stress perfusion as part of their workup. Now, the reason why 76 out of 144 who received gadolinium is partly because not all sites had the same setup in terms of offering adenosine stress perfusion on all lists, and partly because, bear in mind, patients, majority of them had been hospitalized due to respiratory problems, and they may have been discharged on bronchodilators, had a new diagnosis, possibly reversible airways disease, and given the overwhelming burden of inpatients with COVID at the time and the pressures on healthcare resource, we didn't want to push the agenda in terms of adenosine stress perfusion. But nevertheless, 76 had adenosine stress perfusion, and roughly speaking, this takes us about 45 minutes to do a full protocol, including mapping and ischemia testing. So in terms of the results, we found abnormalities in terms of late gadolinium enhancement and or inducible ischemia in 54% of individuals. So just under half actually had normal cardiac MRs, 54% were abnormal, and this is in contrast to the previous study I mentioned that had 78% who had abnormalities, in whom only a third had been hospitalized. We had a median of 68 days from COVID diagnosis to cardiac MR. And in terms of the split of mechanism of troponin leak, or potential mechanism, should I say, myocarditis-like scar was found in a total of 28% of individuals. Infarction and or inducible ischemia, also in 28%. And of the overall 148, dual pathology, ischemic and non-ischemic, was found in 6%. So if I break these down, if we look at myocarditis-like injury, so these are T1 and T2 maps and also late gadolinium enhancement images in a patient who had evidence of myocarditis-like late gadolinium enhancement, and also evidence of very focal myocardial edema. So you can see in the bottom pictures, there's subepicardial late gadolinium enhancement in the basal lateral wall, also a little bit distal lateral, and also some mid-myocardial in the distal anterior and distal septum. And this actually correlates in the basal lateral wall with elevated T1 and T2 in this individual. So this individual actually had some evidence of residual edema. Whilst myocarditis-like injury was found relatively commonly, 28% of individuals, it's important to actually specify that this was limited to 3 or less segments in nearly 90%. And there was no evidence of associated ventricular dysfunction with these findings. As I said, there was residual focal edema in up to 30% of individuals. So slightly different to the other study I mentioned. In terms of ischemic pattern of myocardial injury by CMR, so we found myocardial infarction in 19%. Here you can see subendocardial late GAD in one patient, corresponding to that occluded OM. And we also found inducible ischemia in 26% of the patients who underwent a stress perfusion study. So we didn't select out stress perfusion on pretest probability, it was done purely on a sort of availability and safety basis. But a quarter of the patients who had stress perfusion had a significant abnormality. It's worth noting that 2/3 of these patients had no prior history of coronary artery disease. And of all of these patients, 95% had at least one cardiovascular risk factor. So I think given how many patients actually had an ischemic abnormality here, given that 2/3 had no prior evidence of coronary artery disease, I think it's probably likely that, given that this is not all just previously undiagnosed MI, an alternative hypothesis is that a proportion of MIs actually happened during their acute hospitalization. And so this takes me back to a case that isn't included, because this is a case that of in-hospital type 1 MI. This is a patient who presented with ST elevation MI. It's actually the very first case I reviewed on CCU in my first week on call in the first wave of the pandemic. And ironically, Mariana was with me on the coronary care unit at the time. And this case slightly sparks our interest in actually taking this investigation forward in terms of the what ended up as a multi-center registry study. This patient presented with ST elevation myocardial infarction. He had significant right forearm pain and actually underwent a CT angiogram because of concerns over vascular injury. It turned out he just had hematoma. But this incidentally picked up aortic thrombus as part of the study. There was also concern that maybe part of the lung wasn't perfused, albeit it wasn't gated as a CTPA, so that he then went on to have a CTPA which showed pulmonary embolism. After that, his antiplatelet and anticoagulation strategy were amended, and he then re-occluded his stent. And on OCT, optical coherence tomography of his stent, it was actually a well-opposed stent. He just had an incredibly high thrombus burden, and I'm sure everyone on this call has seen sort of similar, very prothrombotic individuals in acute COVID-19. But I recall this patient because he went for an inpatient CMR because of concern over LV thrombus. And I think the interesting finding is that not only does he have MI in the culprit territory that he came in with, he has evidence of MI in other territories. So whether or not he had microangiopathic injury, sort of, microvascular thrombus, but also he had diffuse edema and possibly myocarditis like leg gadolinium enhancement as well, so dual pathology. So, very inflammatory condition. And I think it's illustrative of how unwell some of these patients were during the acute admission with what was predominantly a respiratory illness. Importantly, if I go back to the comments about edema, I wanted to sort of emphasize that we found focal or regional edema in 30% of those myocarditis pattern patients. There was no evidence of diffuse fibrosis or diffuse edema in the remote myocardium, so in the myocardium remote to the area of scar, in any of the patients. So these are the T1 and T2 values. Now we have pre-pandemic healthy volunteer controls here and also pre-pandemic comorbidity match controls here. That's actually quite useful because obviously given the fact there was concern in the German study about mild disease conferring abnormal T1 and T2, it was important we have pre-pandemic controls. But in order to ensure the validity of these controls, we've actually had this is a phantom controlled study. So we had phantom data from our scanner pre-pandemic. And so we were able to compare that with the phantom data at the time of this study, and there was no significant difference. So using the data from pre-pandemic was absolutely fine. It was a meaningful comparison. And we also scanned that phantom at the 3 other scanners in this multi-center registry to ensure that we could pool the data. There was no significant difference amongst the sites on the phantom controlled study. The phantom had a minimum 8-hour equilibrium time in each scanner in the magnet room. The same protocol was scanned at each site. They were all the same manufacturer, 1.0 and 1.5 Tesla. So we feel that the control population is robust in terms of demonstrating no diffuse fibrosis or edema. So to summarize our multi-center registry, as I said, these are all hospitalized COVID-19 patients who were troponin positive. A proportion, 28%, showed evidence of inflammatory myocardial disease, so myocarditis-like scar. It's important to note that the majority, it was a limited extent with no functional consequence in terms of ventricular function. We've also shown just over a quarter of patients having ischemic heart disease. Importantly, 2/3 having no prior evidence, no prior history rather, of ischemic heart disease, leading us to the hypothesis that a proportion of this infarcts happened during the acute illness. So whilst obviously pre-existing coronary artery disease is going to be important here, I do think some of these events were acute. Nevertheless, I think overall we've shown that CMR is useful in actually defining why a lot of these patients had troponin positivity. It's shown a lot of important disease. It's been clinically important. The vast majority of these patients have ended up having revascularization of some sort because they had significant burdens of ischemia. Importantly, we didn't detect diffuse fibrosis or edema in a particularly sick cohort of patients, hospitalized troponin positive patients. Study limitations. So there is obviously survivorship bias. Now, given the prohibited inpatient mortality that we've shown in troponin positive COVID-19, the data are going to reflect a survival bias. We wanted to investigate and characterize the sequelae of troponin positivity in survivors. So by definition, survivorship bias is inevitable. But equally, CMR scanning in acutely unwell patients with COVID-19 is impractical and doesn't seem reasonable. Obviously, you'd need that to compare with what's going on in the acute inpatient setting. But that's one potential limitation. We looked at troponin on admission in all patients, but we didn't actually do serial troponins. Now, that's the clinical reality of how the care bundle works in terms of the investigation of these patients, but we didn't necessarily look for peak troponin. So it may be that patients who had a negative troponin on admission turned out to be troponin positive later on, and we wouldn't have known about it. But that's just the real world scenario that we were in. Obviously, this is a retrospectively conducted study based upon the recall of discharged patients. And accordingly, we need to take a lot of care in terms of not inferring too much causality. So I think we can't definitely say what's cause and effect. I think it's fair to say that there's such a significant burden of unmasked ischemic heart disease and a larger than expected burden of myocarditis like scar, that there is probably a fair proportion of this that's related to the recent illness these patients had. But nevertheless, this is also fairly early on after their discharge. So whether or not things will change further down the line, what the significance of this is further down the line, that's a matter for future studies. And then finally, historical rather than contemporary controls. But nevertheless, as I say, we've done a phantom controlled study to ensure that these are actually meaningful comparisons and accurate. So having seen these data, then the question comes around, well, should we be screening all patients with COVID-19 infection with a cardiac MRI, given the concern that mild COVID-19 could cause myocardial injury? And hopefully I can reassure you that the answer should be no. So I'm going to show you data that's just been accepted from James Moon's group in JACC Cardiovascular Imaging. It's currently in press. The aim of this study is to detect cardiovascular changes after mild COVID-19 infection. And the subjects are derived from the COVID Sortium healthcare worker study. So this is a study that James Moon has been leading on. And this paper is joint last author with Charlotte Manisty and Tom Tribal. Essentially, the COVID Sortium healthcare worker study, these are healthcare workers from London across 3 hospitals in the first wave of COVID. They were recruited and they underwent weekly antibody and PCR testing over a 16-week period. 21% of these individuals seroconverted, and then all of the seropositive individuals were invited to take part in a cardiac MRI nested case control study. So of those 157, there were 13 who had left the hospital or had contraindications to CMR or had left the study. 70 declined, and that left 74 individuals who underwent a cardiac MRI. And these were age, sex, and ethnicity matched with 75 seronegative individuals. In terms of the definition of mild infection, 61% had case definition symptoms, 24% non-case definition, 15% were asymptomatic, only 1 individual was hospitalized. So very much a mild infection cohort at home, the vast majority, 73 out of, only 1 patient being hospitalized rather. And they all underwent multiparametric cardiac MRI and also measurement of aortic distensibility. They didn't undergo stress perfusion. And the CMR analysis, it was a phantom controlled study. It used AI analytics to remove some of the elements of human involvement. There was blinded human oversight in the analysis, so any human involvement, the seropositive or seronegative status of the subject was not known. And so this was the setup for the study. And then looking at the results, fundamentally, there were absolutely no differences on cardiac MR between the seropositive and the seronegative participants. So if you look at any of the outcome measures, cardiac structure, cardiac function, tissue characterization, all of the primary and secondary endpoints, primary being in green, secondary endpoints being in yellow, there were absolutely no differences between seropositive and seronegative groups. There were also no differences in blood biomarkers, in particular troponin or NT-proBNP. So no difference in cardiac volumes, function, left atrial size, mass, or any tissue characterization metrics at all. And then if you look at individual cases, so here you can see the 6 patients in the seropositive group who had evidence of late gadolinium enhancement, and 7 patients in the seronegative group who incidentally had late gadolinium enhancement, all of which are non-ischemic, some of them subepicardial, some of them mid-myocardial. But you can see here there's no difference in the overall number of patients who have late GAD in either group, very similar patterns of these incidental findings. And then if you look at this diagram, so 149 subjects in rows, split according to seropositive or seronegative. Age is ranked from sort of youngest at the top to oldest at the bottom. And the markers, so primary and secondary endpoints on cardiac MR, there are 10 of them down there, as well as 2 biomarkers, TROP-T and BNP. These are listed by a RAG score. So red is greater than 4 standard deviations beyond normal. Amber, more than 2 standard deviations above normal, and then green being normal. And you can see here that overall, there are no differences between the groups. Abnormalities tend to co-segregate in rows. So if there is one abnormality, there tends to be other abnormalities in the same row in the same patient. There were slightly more patients who had abnormal septal T1 and T2 in the seropositive group, but this is not statistically significant. And it doesn't co-segregate with late gadolinium enhancement either. It also wasn't reproduced if they did a global T1 or T2 measurement rather than just in the septum. So overall, there were no detectable persistent cardiovascular abnormalities 6 months post mild infection with COVID. Bear in mind, as I say, this is 6 months post-infection, whereas our cardiac MRs in our study were earlier on. I think the median, as I say, was roughly 60 days. And the conclusion of the paper is that these asymptomatic or mild infection patients should not be screened with CMR, which I completely agree with. Just looking at future studies, so you can see here there's several studies, and this is only a sort of hand-picked selection. We've actually participated in the COVID heart study. We're one centre that's helped with recruitment. This is looking at troponin-positive COVID-19 individuals in terms of early versus late convalescent cardiac MR, to see if actually there's any ongoing cardiac sequelae further down the line, and to look at the importance maybe of some of the findings that we found in our earlier study. COVID-19, that's a post-hospitalisation study. It's a national consortium to look at long-term health outcomes in the UK, aiming to recruit up to 10,000 individuals, including cardiac imaging in that study. And Cisco-19, that's a multi-centre observational longitudinal cohort. It's looking at 2 time points. It's got very broad inclusion criteria, minimal exclusion criteria. It doesn't include renal dysfunction, for example. And the primary outcome evaluation is cardiac imaging at 28 days post-discharge. So I think a lot of studies aiming to address some of the concerns regarding findings on cardiac imaging. And I think actually will help us understand and hopefully reassure what some of these findings mean in the long term. So just to summarize, elevated troponin, it's common in COVID-19, as you have seen. And I hope from our experience that you'll agree that CMR has been a useful tool in the evaluation of these patients, both in terms of understanding the mechanism of disease and also the clinical application. In the myocarditis-like injury pattern of late gadolinium enhancement, we've shown limited ongoing localized inflammation. There's been no diffuse myocardial edema or fibrosis found. We've got to be careful not to infer causality in all abnormalities that we have found, albeit I think it's fair to say that we've seen a higher proportion of abnormality than we would expect under normal circumstances. And then in terms of the long term, what this means in the long term, I think that's what some of those future studies are hopefully going to help address. And so I'd like to thank these all my co-workers at the Royal Free, in particular Mariana, who's next door I can hear, and also Touche Architecture, all of our fellows, all of our colleagues in the hospital, all of our colleagues actually at UCLH and at Imperial Healthcare Trust as well, and also to Peter Kelman and Hui Ji at the NIH, who help us on an awful lot of things that we do here. So thank you very much, and I'll hand back.
Great. Thank you, Dan. That was wonderful and such a great review. I'll put in a quick plug that as we get going with our NIH MRI collaboration here, Peter Kelman and his group are going to be engaged with us as well. So a lot of this sequences and the like will be available here too, which will be very exciting. Just a quick question for you, and then I'll turn it over to the rest of the group. In the study that you all did across a few hospitals on the sicker patients, on the ones that were inpatient, Was there a control group that you all were following? And as far as the reads go, was it clinical reads or were these blinded reads by people not knowing the status of the patients? You know, you mentioned in James Moon's study that he uses an AI algorithm or used an AI algorithm to try to get some of the human bias out of it. So I'm just curious how you approach it. And I'll take 1 second to just give a plug to a sister institution that has nothing to do with us. But for those of you who are interested, James Moon gives a wonderful talk about the future of AI in imaging. And he gave this as a grand round at Montefiore Hospital, who puts all of their talks on the web. So if you search Montefiore Hospital and James Moon, AI and imaging, it's really a wonderful talk. Sorry for that long introduction to my question. Dan, what do you think?
So I think it's a very valid point. And the way we try to get around bias, as it were, is to at least subject ourselves to each other's interrogation. So obviously all patients had a clinically issued report. They were clinically read, but by definition, they were all troponin positive. So all of the controls were historical. We didn't have any contemporary controls. So by definition, people coming in for CMR came in because there was a concern there was an abnormality. Now, I do remember us all being packed into Mariana's office one afternoon with Peter also on Zoom we blinded obviously patient demographics and identifiers and things, but essentially doing a sort of an analysis amongst, there were 4 of us at the time, all doing our own sort of interpretation of the findings to actually make sure that we concur rather than it being a sort of one person looking for a problem as such. But by definition, you're right, they were all troponin positives coming into the scanner. So we all had a sort of a suspicion of finding an abnormality. But nevertheless, I don't think there was any, we didn't, when we have done reproducibility within the unit for other studies, we're pretty well matched in terms of what we call. I don't know whether that, I mean, Mariana and I have been here both at the same time since early 2016. So it's either the blind leading the blind, or hopefully that we're good at what we do and we're reproducible and accurate, I hope. But yeah, you're right. I mean, I think the difference with James's study is by definition, half were seropositive, half were seronegative. And they were blinded to those data. So yes, that is a limitation, but nevertheless, and without a shadow of a doubt, the ischemics were all pretty profound. There was no subtle ischemia in these individuals. It was pretty barn door. And actually, what was interesting, recalling this, we had one colleague who was actually starting maternity leave before giving birth and was actually just finishing off reporting and actually did a bunch of clinical reports remotely because obviously the pandemic was on, and was reporting them remotely, not knowing what we were up to. And so we compared our calls with her reports as well. So there were a couple of internal mechanisms to try and make sure it wasn't just one individual going through scans looking for particular things. But you're right, there was no control group at the time to mix them up with.
Steve Epstein, I see you there.
Yeah, thank you very much. What a wonderful overview. I wish you had gone a little at half speed, but
apologies.
But it was
mindful keeping an eye on the clock. Sorry.
It was really brilliant. But I do have to say, you know, the fact that you had as your control group patients with elevated troponin, it doesn't matter how accurately you're reporting the data or whether there's variation between different readers. I mean, if you could just hypothesize, as I think Gabby was sort of implying, that everybody you studied as a control group had elevated troponins and therefore did have myocardial disease, so that although there was no difference between your COVID positive and your COVID negative controls, they may have had something. So, you know, let me throw out the terrible conclusion. I don't think we could conclude anything from your study, given your control group, I would say, had myocarditis. Rebut that, because I may have missed some critical things during your presentation.
Yeah, no, so the control group, we had two sets of controls. We had completely healthy volunteers, as one control group, but we also had comorbidity matched controls. So we're talking things like hypertension, diabetes, etc., sort of background conditions that could cause, abnormalities, because we were wanting to look for any sort of diffuse problems as well as focal problems. And that was particularly in looking for diffuse fibrosis, diffuse edema, as by T1 and T2 and things like that. So they were those two sets of controls there, so that we weren't just comparing health and disease, and we know there was a high comorbidity alongside COVID in the patient population. We wanted to make sure that we matched for comorbidity as well. So there were two control groups.
Mm-hmm. And the controls, the healthy controls, yeah. Was there a difference in your T1, T2 gadolinium results with the COVID positive patients?
In terms of compared to the COVID patients in the remote myocardium, so remote from the areas of injury, the T1 and T2 were not different between the COVID-19, the controls who obviously didn't have COVID and who were comorbidity matched, and the healthy volunteers.
No, I mean the overall incidence of abnormalities, whether they were remote or non-remote. So
we didn't find in our our healthy controls, we didn't have abnormalities. In our comorbidity match, they had normal cardiac MRs. So they were matched for comorbidity, but had no cardiovascular disease, because we wanted to make sure, because you can in infarct have areas of high T1 or T2 remote in the remote myocardium. So they were basically, those controls were purely for the T1 and T2 for the diffuse fibrosis and edema part.
So how strong do you feel that, what is your definitive conclusion, as definitive as it can be, as a result of these really fascinating and relatively, well, they were kind of small studies, but what do you conclude so far?
So far, I think it's unsurprising that we've found a high degree of abnormality, because by definition, we've had evidence of cardiac injury whilst they're an inpatient. And I think the thing that really surprised us was the burden of undiagnosed ischemic heart disease, which is actually therapeutically very important in terms of their ongoing management. So we found, given, I think it was roughly 28% of individuals who had either infarct or inducible ischemia, and 2/3 knew nothing about it beforehand. That's actually quite a lot, that's quite a high burden. And it's unsurprising, as I said, given that, 95% of the patients who had reversible ischemia had at least one cardiovascular risk factor. So I think that conclusion is important, because, as I said right at the start, clearly they're a vulnerable group with COVID, and it's important that they're identified because it has therapeutic implications. I think from the point of view of the myocarditis pattern, I think it's useful that we found a potential mechanism for troponin leak as an explanation. I think it's reassuring that they don't have significant functional consequence. We are following them up clinically, so that all of these patients are being followed up as part of a routine clinical practice. But I think in this setting, it's a useful test to do. But I think conversely, I think in milder asymptomatic disease, we shouldn't be doing any sort of screening as such for cardiovascular abnormality, because I think, as James's study shows, in that particular type of patient, there isn't any COVID-related abnormality.
Thank you.
Bill.
So this is a really wonderful talk. I agree with Dr. Epstein in that regard. Despite the enormous incidence of COVID-19, the advanced imaging studies like this are still relatively small numbers. And as you point out, there's really significant danger of selection bias as to these patient populations, making it somewhat difficult to generalize. Nonetheless, I, like you, find the results relatively reassuring if people don't have what appears to be acute ischemia or inducible ischemia. And so I wonder your feeling about the clinical implications of that, and just where are we? Because people are extremely concerned about returning to normal function after COVID. If they don't have the neurologic sequelae and the psychological sequelae, they may think, well, I'm ready, I'm good to go. But are they? Can we really be reassured, allow people to return to sports, either competitive or non-competitive sports, or do we need much more information before we can really safely say that patients who don't have inducible ischemia, even if they have some degree of myocarditis, are going to fare well?
Yeah, I think it's a fair point. I think it depends upon the patient, the cohort that's being looked at. So, I think, it's really important that in mild asymptomatic disease, etc., we shouldn't be screening these sorts of people with cardiac MR, because as James has picked up, you find very little, and it's incidental findings. By definition, I think troponin positivity warrants further investigation if it's appropriate in that individual patient. And I think that, I think the management of those patients in the setting, if they have had severe COVID-19 and they have had an indication for a CMI in terms of biochemical evidence of myocardial injury, then they need to be managed according to a normal clinical pathway. But I don't think, unlike sort of some of the articles that were suggesting that any athlete or any sports person who's had COVID-19 should then be screened, my personal opinion is no. We're looking at, the ones in our study, we're looking at the severe end of the spectrum, and they just got a troponin at baseline regardless. So I think we were duty bound to investigate them. But no, I think the fact that they got back with the sports programs, I think was the right thing to do. I don't think we should be screening all sports people who have had COVID, just as we wouldn't do with any other viral infection, unless they had an indication in terms of symptoms or other tests that they might have had done for whatever reason.
I'll ask a quick question, and then Steve Goldstein, I see you. Dan, I suspect at this point in time, the numbers aren't quite there for you to say too much about this, and I'm very excited by all the studies that you showed are upcoming. I mean, the UK is doing a great job in collecting data and educating us. But when COVID started, it was just COVID, right? You had COVID, you didn't have COVID. Now we're starting to understand variants. Not me personally, but we start to hear about these variants. Do you anticipate that these variants may be meaningful? Are you guys starting to add variant data to looking at the CMR? Would we expect, or should we be looking for differences in variants and how they affect the heart?
I'll be honest. I agree. Well, I like you. I think I'm probably not, not that well versed in knowing the answer to that, if I'm being honest. In terms of the variant identification in the UK that's going on is based upon random sampling of the population, and then we find out if a particular area has a little surge, like in South London at the moment, there is a surge of the South African variant, worryingly. Then we find out that way. But very much in terms of what's come through our front door, this has literally been sort of generic COVID-19 diagnosis. I don't know is the honest answer. Don't know. My gut feeling is, from what I've seen so far, is that the main difference in the variants has been the degree of contagiousness rather than severity of illness, but that's based very much upon a limited look at the field.
Well, you're seeing almost entirely the UK variant now in Great Britain, correct?
So that was responsible, yeah, so in the November, December time, that was responsible for a large part of the second surge, and when they did a sort of mini lockdown before Christmas, because the government were pretty much aiming to try and have a normal Christmas period, why things hadn't settled down, because the degree of contagiousness of that variant, the so-called Kent variant, it came from a region of sort of southeast England in Kent, or at least that's where it was first identified. That was the overwhelming driver of our second wave. Yeah.
Steve.
Yep, this is an aside from your excellent presentation and wonderful data. And just curious, my impression from reading the newspapers is that Great Britain is generally doing better than the other European countries. Where do you stand now, a percentage of Brits vaccinated? What's your number now, more or less?
I'm glad you qualified that with the comment about it being to do with vaccinations rather than doing better at anything else, because I think this is personal opinion only and not representative of institution, etc. That's the disclaimer. But yeah, there was a little bit of concern about how, initially the country was managed in terms of, being slow to lock down, things like that, in terms of being slow to sort of shut down certain, international travel paths and things. So there was criticism of the government, I think, and there was a lot of it that was justified in terms of its handling of that. There were definitely lessons they're going to have to learn. But you're right, the vaccination program, I have to give them a lot of credit. So at the moment, we've got 32 million adults vaccinated with their first jab at least. I think it's about 5 million who've had a second jab. And at the moment, it's gone both in terms of vulnerable groups first and in terms of the oldest first. And so at the moment, we're now in the 40s. People in their late 40s are being offered jabs in the community. And that's patients, that's just individuals without significant risk. So the vaccination program is really going very, very well in that regard over here, yeah.
Thank you.
Thanks.
Other questions? All right, well, if there are no other questions, Dan, I just want to thank you again for that wonderful review. Congratulations really on a nice body of work, and we look forward to the next iteration of data to come from your group and others in your region. Thank you for presenting.
No worries, thanks for inviting me. Thanks very much.
Thanks, Sam. Good
Bye-bye.
to see you.
Thank you.
Bye.
Bye-bye.